I did make some copies for you that are from that book that I really like that I can't make you buy. That talks about how you can relate the concepts of perfusion with the cardiac system. So that's, you don't have to look at all of them, but I just made it for you because some of it's really nice. It's down and dirty about how you connect the dots about what's happening with perfusion. So it is something that you will see. But of course, we have to talk about that. You weren't going to get an exam without having content presented to you. So that was the first thing. More than likely, what's going to happen is we'll have some class days that are going to be added on later in the semester. But I'll let you know that ahead of time. But it's going to be probably towards the end of October, so that you have plenty of time to schedule if you have to schedule stuff. But when you talk about the cardiac system, it really is, I mean, it's a lot of chapters, a lot of stuff in the chapters, but you got to try to make it so that you can see the forest for the trees when you're looking at it. There's a lot of stuff in there, but not all of it you're going to be tested on. A lot of it you did have, well, I mean, not a lot of it, but some of it you had in our MP2 class. So you had some of the, it's now laid the groundwork for looking at the other stuff that you're going to do, because we talked about stable angina there, so now we're going to talk about MI here, cardiogenic shock, those types of things. So you will see the continuation of things like the worst case scenario about what's happening with your patient. So that's what you're going to end up seeing. So the first thing, of course, you got to look at some of the basic stuff about going with the cardiac system. So knowing the structure is going to help you figure out what patho is. Because always when the body is affected, that's what produces the symptoms in the patient when you talk about cardiac stuff. And most of the things, as you know, have to do with that mismatch between myocardial oxygen demand and supply. So that's the biggest kind of area that we look at for what's happening with your patient. And understanding that whole process of atherosclerosis, because it kind of underlines pretty much everything that goes wrong with the cardiovascular system. That's what's weird about it, but it's also one of the things that kind of helps you not get so crazy. All right, I know you got crazy. We'll get over that part.
Crazy.
It was crazy because a lot was going on. A lot was going on, so that pretty much ended up where that goes. So one of the things you got to kind of think about what's happening with your patient, of course, is making sure you look at the heart itself, the heart and the vesicles, and understanding the AAP of the heart and what's going on, what happens on the arterial side versus the venous side. Because that's always going to help you figure out what's happening with your patient. So you know the heart is about the size of your fist. Now remember, as pathology happens, or you see things like hypertension, cardiomegaly, cardiomyopathy, that makes the heart bigger. So that also changes where you do your assessments on your patient because of that. Because we are all taught that where is your mitral valve, where do you listen? Left, fifth intercostal space, mid-clavicular line is where you look for mitral. So that's, and it's actually the loudest valve, that's because it has the most pressure to overcome to get to the periphery. So that's why you hear it the loudest. And that's why they tell you to listen to the mitral valve when you're doing your apical pulse, because that's going to be the loudest one. But if you have a person that has pathology of the heart, that it gets bigger, floppier, that you see with patients who have cardiomegaly, patients who have cardiomyopathy, you may actually have it displaced to the 6th intercostal space, 7th intercostal space. That's a huge chart that sometimes you do see in patients who have cardiomyopathy, or CMO, as you'll hear it abbreviated when we're talking about patients. So just know, thinking about where you listen to, where you put your stethoscope, maybe things that come up when you talk about testing. But I will tell you, just like the NCLEX exam, it's going to test you on things, and the thing I do is test you on what you see most often. So even though you have 4 valves, the one that is diseased the most is mitral. So that means when you're looking at the pathology stuff for valvular disease, you're going to go mitral. The second valve that's affected most often would be aortic. And if you think about it, those have the highest pressure to overcome, so that's why. Those are the valves that actually have the most damage or things that happen to them. You very rarely see, although it does happen, patients who have issues with tricuspid or pulmonic valves. But it does happen, but it doesn't happen as often. So that will be things that you actually see happen with your patients. So just when I'm going to bring up the page now that that's on your class site to kind of think about where you're going to see for information for the course.
What's up? Yeah, but nothing, no increase anywhere. Awesome. Good news. Huh? Okay, okay.
Now, one of the things to help you see the forest for the trees kind of thing.
Okay. That's good news. Good.
All right. When you look at your front page for your class, and you do your cardiac section, that first thing that you have down here that talks about MPO, cardiovascular,
Alrighty.
now each one of the areas down here, these are the PowerPoints for the class, so it has all the stuff that's there. But this is kind of where you need to focus your, I have all that stuff down there where you need to focus your, what you're going to do as far as your study goes when it opens. You mentioned before I have but it's basically going to show you when it does open is that pathology kind of fits into three basic areas when you're talking about cardiovascular stuff. Now on the sheets that I gave you, it does it a little bit different, but it's still the same kind of process about you thinking about what's happening with this patient. All right, when you're thinking about stuff that you're going to be looking at and what we're going to be treating the patient for and why it's important, is to kind of look at three basic bundles of things that can go wrong with your patient. So first you have our electricity, and even though my friend here was going through all that stuff, the only ones, the rhythms you got to worry about is atrial fibrillation because it's commonly occurring. Ventricular fibrillation and VTAC are things that happen. Those are lethal arrhythmias that happen to patients. That's why you need to know those. The only other one that you're likely to see when you go into your NCLEX exam would be asystole, because those are the major ones that talk about what happens with your patient. And because that's different, asystole is not a shockable rhythm. Asystole, when you have it, means the patient gets CPR. That's what makes the difference as far as making sure you understand those things. And that's when that ABC changes to compressions first, because you need circulations happening in a patient who has asystole. But if you have a patient that has VTAC and VFib, those are things that are likely rhythms that you're going to treat with shock. There are medications that we can use, but those are things, those are usually the lethal arrhythmias that kill folks. So those are the ones you got to know. Atrial fibrillation you got to know because it's common. Pretty much a lot of times people can be walking around their regular life not even knowing they have AFib until they go and do something like, I'm going to have a knee replacement, I'm going to have surgery, this type of thing. They put them on a monitor, and lo and behold, the patient is in AFib. Now, doctor's not going to treat whatever problem the patient was coming in the hospital for until that AFib is corrected, because nobody ever wants to do surgery on a patient who has AFib unless you anticoagulate that patient, because that's the issue. The atrial rate, the heart is just quivering. Those momentary quivers produce clots. That's why patients who have AFib are on anticoagulation. You've seen that all the way through nursing school, and you probably see it in your lifetime, people outside the hospital, but that's the reason why you have to do that. So managing those arrhythmias, you gotta know, okay? So then we're gonna talk about sudden cardiac death, and the underlying rhythm that you see with that is VTach and VFib. That's usually what produces that. Sudden cardiac death is just that person living their life, not having a problem, all of a sudden drops dead. That's why you see AEDs all over the place, okay? Because that's usually the rhythm that causes the problem. It's a shockable rhythm, and the earlier you shock the patient, the better likelihood that the patient is going to live on the other side. So that's why you see and got to know about that kind of stuff. And then we talk about the presentation, because a lot of times when you have a patient who has sudden cardiac death, the two things they work the patient up for is having a heart attack that caused it, and if the heart attack is not the problem, then it's electrical. So that's why you have those two kind of things going on there. So if you have a patient who has those arrhythmias, then what do you do for them? Are there electrical treatments that we do, medications that we do? So we're going to talk about those as we go along. And then I put some medications down here for you to look at, because those are the common meds that you see when a patient presents with one or more of those rhythms. So those are the medications: lidocaine, beta blockers, Coumadin, and heparin. We also should have calcium channel blockers in there, because that's usually atrial fibrillation. Okay. And then some of your diagnostic tests are, of course, EKG, Holter monitor, electrophysiology studies, especially if a patient ends up with the sudden cardiac death rhythms. They always go into an EP study. Electrophysiology tells you where the arrhythmia is happening. Can I burn it out? Get rid of that that's happening in the patient. And then some of the things that we do as far as correcting the patient's ablation, where they go in and figure out where it is and get rid of that spot, or a pacemaker. So we'll talk about that. And how you can recognize where the patient has a pacemaker in the hospital. We don't talk so much about having that on a test, but you need to recognize when a patient does have a pacer that's working or not working, or you can tell where it's placed because of where your spikes are. So that's the kind of thing that gives pacemakers away. So that's the electricity side. Now the thing about it is, no matter what the condition is that you talk about in the cardiac system, it can have a decrease in cardiac output. That's why the patient is symptomatic. So they're either going to have chest pain, or they're going to have changes in level of consciousness, blood pressure low, pulse rate high. All those things are kind of going on with the patient. So then we get into the structural stuff, which is the biggest part of what you have. So we have, of course, acute unstable angina, a coronary artery disease, and atherosclerosis, understanding that whole process about how it happens. The bad part about it is that we all pretty much have it at some degree. That's the thing. But this kind of stuff that you have to do to teach patients about reversing the lifestyle changes that kind of go along with that. So unstable angina, acute coronary syndromes, MI, and we have mitral valve dysfunction of varying types, meaning that you have regurgitation, insufficiency, stenosis. Now, even though the other valves are there, they are not diseased as often. The mitral one is the one you see most often, so guess what's going to be on the test? Mitral valve disease, okay? So then we have aneurysms, which is the outpouching that happens. And most of the time you hear about it in the aorta, but it can happen anywhere in the body. So we'll talk about that as well. And then we have acute arterial occlusion. That's where you actually have a clot that now goes into the path of least resistance, now causes some decrease in perfusion that happens with that. Then we have the inflammatory conditions of endocarditis, pericarditis. They kind of give it away, the location of what's happening with the patient, because it gives you the structure. Endocarditis is going to be inside the heart. Most of the time you talk about that as far as valves, but endocarditis can actually affect the whole chambers inside. So it can be all over, but most of the time it affects valves. And we'll talk about how you can pick that up in a patient. Pericarditis is more rare, but you tend to have a lot of chest pain when patients have pericarditis, but because it's not an MI, there's no changes that you see in the EKG other than it raises the chest leads off the baseline. So we'll talk about that. But that is more of an inflammatory process. So you actually treat the patient with anti-inflammatory drugs as opposed to antibiotics, which makes it different from what you think about most things, because endocarditis is antibiotics, long term. You're talking about 8 to 12 weeks minimum when you talk about endocarditis. The cardiomyopathy is a big floppy heart. This is a person that usually has had some, you don't know, most of the time it's viral illness, but can also happen associated with drugs, different inflammatory disorders, alcohol, so different reasons that your patients can have it. When you look at your book, there's a dilated and a restrictive type. Dilated is the most common, so guess which one's going to be on the exam? Dilated cardiomyopathy. So that's the one you're going to see. And if you ever watch the movie Beaches, that shows you, because she was the person that presented with all the signs and symptoms. Barbara Hershey's character is the person that has cardiomyopathy. And the thing about it is the pumping efficiency of the heart gets so low the patient can't perfuse organs, can't perfuse systems, so they end up dying unless there's no way to fix it. The bad part about it is the vast majority of patients, we don't know why they get it, and even if you treat the acute part of it, we still have the patients or their families talk about, you know, this is a life-limiting kind of illness. About 25% of the patients end up with some debilitating heart disease where they're like at heart failure number 6. Heart failure is graded from 1 to 6. 50% of the people will be somewhere in the middle. 25% of people get well and never have another problem. So about 75% of the people who have cardiomyopathy end up with some type of long, lingering type of effect from what's going on. But what it does is decrease the amount of the heart is actually able to pump. And so patients end up suffering from that. That's one of those disease processes, not just thinking about testing stuff. But if you end up working with patients with cardiomyopathy all the time, you get it, but people who don't freak out all the time. Very few times do you hold patients' blood pressure medicine, and very few times do you hold DIG. You know how we're used to holding DIG at 60? With a CMO patient, it's usually 50 and below. When you're talking about blood pressure meds, you don't hold it unless there's systolic blood pressure is less than 90 for some. Some doctors don't hold it unless it's 80 or below. So if you ever have a CMO patient, that's one of those things to remember for life. Always call the doctor if you're not sure. If they don't give parameters, call them, because you're so used to holding meds when a person's blood pressure is 90 over 40 and the doctor comes in and has a cow. They really do, they go ballistic. And the reason is because anything that causes their blood pressure to go up, their heart rate to go up, taxes the heart even more. So those are people that we truly say circling the drain, but they're vital signs. We pretty much keep their blood pressure low, their pulse rate low, because that taxes the heart. So what are we going to talk about? Some of the diagnostic assessments, clinical findings that kind of give you the diagnosis that this person has. Same kind of stuff we looked at before. Also to tell if a patient has a STEMI versus non-STEMI. This is talking about an MI. How do you tell the difference? Why it's important? Because you treat it a little different. If I know that a patient has a ST elevation MI, that's what a STEMI is. If the chest pain has an onset of a certain amount of hours, less than 6 hours, that means that's the patient who is possibly a candidate for thrombolytic therapy. So why that makes a difference is because it dictates treatment if I have a non-STEMI versus STEMI. I also know that the sooner I get revascularization, or I can increase perfusion to that area, the better outcome for the patient. The more heart I save. So that's why that's important to kind of look at for what's going on. Okay, so we're going to talk about treatment and nursing care, some of the complications you see with patients who have these disorders. And then, of course, we got medications again. Okay? Most of the ones that fit on this category are going to be things that increase perfusion to the heart or the vascular system. So that's why you see nitrates, and that's all forms. We talk about nitroglycerin. It can be in a pill, it can be IV, it can be in an ointment, it can be in a patch. So remember, nitro is a lot of different ways that we give to patients, but it causes vasodilatation. Therefore, it improves perfusion. So that's what gets rid of the pain that the patient has. But you also have to think about patient teaching when you talk about nitroglycerin. Because can you just take it out of the bottle and put it in a secondary one? No, it should always be stored in the container that it's in, and once you open it, you look at how long it's been open, because it loses potency over time. Okay. They should feel that tingle when they put it under their tongue. If they don't, then it's not working. Okay. If you put topical nitroglycerin on a patient, because we put patches on people, or you may have in your work that you've been doing, you have an order that says put the patch on in the morning, take off at bedtime. People wonder why you do that, but the reason why is because nitrates have a tolerance. So I want it off at bedtime so that patient has a nitrate-free period. Okay, so you'll see that. Sometimes you'll see those orders for a patient. They also have some, even though we talk about oral, most of the time we talk about sublingual, but there's also pills that are nitrates. The Endures, that's the long-acting nitrate. The Isordil is a shorter-acting one. So those are things that your patients can have. So we have aspirin. because, you know, antiplatelet action we want patients to have. Coumadin may sometimes be given for patients, heparin, Plavix, because those are things that patients may have based on some type of intervention that they have. So if I go in and I do a stent placement on a patient, that's the patient that's going to have Plavix. Okay. And then they use some of the newer drugs for that too. We're also going to get morphine, because that's sometimes you have to give a patient who has chest pain, especially if their blood pressure is low. Because there's a difference. If I got a person who has chest pain and I give them nitroglycerin but their blood pressure is low, that actually increases the work of the heart, which makes their ischemia worse. You're thinking that should help. But if you already got a low blood pressure, I give you a nitroglycerin, that lowers your blood pressure even more. What does your body do to compensate for low blood pressure? It increases your heart rate. So that's going to tax the heart even more. So that actually doesn't help the problem. So if you got a really low blood pressure, morphine is the way to go when you're talking about chest pain. It helps to vasodilate as well, but you have less effect for that when you're doing morphine for patients. So we have to do that too. Beta blockers are medications we give sometimes during the heart attack, but especially after the fact. Beta blockers actually have a protective effect on myocardium. Part of the reason why sometimes we go to the hospital and we're looking at things that happen with patients. You look at medications, you can tell what's wrong with the patient. Because you see the things that they're on all the time. We're like, oh, if this patient is taking a beta blocker, they're on aspirin, and they're on a statin drug, they've had some type of cardiac event. Because that's the holy trilogy of medications after a heart attack. They're going to be on aspirin, they're going to be on a beta blocker. Even if their blood pressure is low, you give them the lowest amount that you can give the patient. Because that's going to protect the heart. And metoprolol is the one you see, or Lopressor is the one you see most often given for that. Okay. And then they're on a statin drug because the underlying process is atherosclerosis. So that's why patients take those. Okay. And then the thrombolytics are going to be those things that you give during that patient. That's the TPA. Those are things that are going to be the clot busters. When that patient has a STEMI, you got to look at those types of things. So then we're going to talk about some of the other diagnostic testing there, of course, cardiac cath, angiography, CPK, and myoglobin has come back. I got to add that one to the thing because myoglobin went away for a long time. And now you can do it because they have a fast one that will show you if heart muscle is affected within 2 hours. So myoglobin is done at the bedside now. But it went away for a long time as being a test that you use for that. The most specific test that you see when you talk about patients, when you talk about cardiac damage, is going to be troponin. CPK can be elevated for a lot of different things, but if it's CKMB, that tells you it's heart attack. Because CK can be elevated if you have a stroke, can also be elevated if you have muscle injury or myositis. If you fell, you know, you got people that fall and they were on the floor for a while because it's going to be released from muscle. So if you got a person who has a CPK of 16,000, you're going like, oh my God, that's a huge heart attack. Make sure you look at them when they do what they call fractioning it. They're going to tell you where it comes from. So BB is brain, S is skeletal muscle, so that's people that have some type of injury going on in that just general muscle. And then MB is myocardial bands. That tells you it's heart. We're also going to talk about some changes you see on EKG that will tell you ischemia versus tissue or death, which you see with necrosis, which you have to kind of differentiate what's happening with the MI. And there's some other lab work, CBC, Holter monitor. PET scanning is usually done nowadays after the person has a heart attack and you keep seeing this person keeps having episodes of heart failure, this kind of stuff. PET scanning is going to be very specific for telling you how much of the myocardium was salvaged after the heart attack. It's not done at the time the person has the heart attack. It's usually done a few months afterwards so we can see how the muscle uptakes the contrast. And you're able to tell how well the pumping force of the heart is. So those are things that you sometimes do as a monitoring piece when you keep having heart failure, that you'll see that for patients. And of course we can do echo. Echo kind of tells us more than like it tells you, it can give you an ejection fraction on the patient without doing a cardiac cath. But the other thing it does is tell you where there's vegetation on the valves. So those are things that they use for that. We can also do a PTCA. That's where the patient goes in for cardiac cath. PTCA is percutaneous transluminal angioplasty. All right. So they're going in. That's what they're considered. We used to call them roto-rooters, but now what they do is go in, open the balloon, Sometimes, and the plastic piece of that, when they're talking about transluminal angioplasty, is they're going in, opening the area where you have the blockage and plastering that plaque against the wall. So that's the plastic piece that goes with that. Most patients, as you know now, get a stent. Okay, everybody wants a cardiac program because that's where your hospital makes money. But when you talk about stents, those add another $5,000 to $7,000 based on count. And some people get 3 or 4 at a time. So those are things that they actually do for your patient. Then the catheter course is coronary artery bypass grafting. That's actually where they're going in doing open heart surgery to bypass the area of blockage in the patient. Sometimes that's done the very first time a patient comes to the hospital. Sometimes it's done after we tried to stent you 5, 6 times. You've been in and out. Now we have to actually go and bypass those areas because we can no longer stent anything in the patient. So different reasons that why your patient may have that. Sometimes it can be done because it's a complication of a plastic. They tried to go through and open the area and actually went through a vessel. That's immediate open heart surgery. So that's the worst case scenario, but it can't happen to your patient. Sometimes they'll do an embolectomy that usually can be done if they're instilling medication at the site of the thrombus. So they can actually do embolectomy there as well. But most of the time they're going in to do instill medication to break up the clot that's there. And then of course the valvular surgeries. There's going to be either valve replacement with a homograft, which is something that a human graft, or an allograft if you're using pig valves. Or you can actually do a mechanical valve. So it just depends. The nice part about it is if you do a homograft or an allograft, those patients only take aspirin. If you do a mechanical valve, that will always require anticoagulation for the rest of their life. But they tend to last a long time. So that's why you'll see patients actually have that.